The purpose of the airway evaluation is to predict, identify, and manage a difficult airway, and to reduce the complications associated with a difficult airway. These are injury to the teeth, airway trauma, unnecessary tracheostomy, cardiopulmonary arrest, hypoxic brain injury, and most serious of it is death. So what are the factors influencing the airway-related complications? And obviously the patient factors are more important, which are airway anatomy and what kind of vital organ reserve they have when they are being sedated or given given anesthesia. And what are the clinical situations of the patients are being sedated, and what are the airway resources available at that time, and the skills of the practitioner, what kind of skills practitioner has to manage that situation. According to the closed ASA claims database, the failure to evaluate the airway and predict difficulty is the most single important factor leading to a failed airway. So how does this failed airway present? It presents in two forms. Recognizing and moving quickly to alternatives is critical. In the first situation, you have time if you can ventilate the patient and oxygenate, but cannot intubate the patient, you still have time to try other things. In a second situation, you have no time at all before you take a critical decision to maintain the airway when you cannot ventilate and oxygenate and intubate the patient. Incidence of difficult and failed intubation. Difficult intubation is about 5.8% in overall patient population, and in obese patients is much higher, which is about almost 20% in obese patients. And the failed intubations, fortunately, are very rare. The incidence is about 1 in 2,230 patients, or 0.05%. And it's much higher in obstetric population, which is 1 in 750 patients or so. So obese patients and pregnant patients, the failed intubation rate is much higher compared to general population. Be able to do supraglottic device in this patient, or can I do the intubation, or if there is any problem with it, all the above three, is there a way I can do a surgical airway in these patients, or is there a means to do it? The ASA, they have a consensus guidelines in terms of difficult airway management. They think that the history, getting a pertinent focused history and physical evaluation will lead you to a better prediction of the difficult airway. These are the common things what we need to focus on when you're asking for the history. And obviously if the patient gives history of difficult intubation, it's very important to note. And if the patient has any symptoms of snoring or history of sleep apnea, asthma, and any surgeries on the C-spine because of the mobility problems, or radiation to the neck, or if there's any obvious anomalies of the airway, arthritis of the TMJ joint, or if the patient has any protrusion of the teeth, type 1 diabetes. A lot of people might not pay attention to this disease if it is long-lasting. There is glycogen deposit in the soft tissue membranes, and this can be very rigid in terms of the opening the membrane, the airway. And pregnancy, because of the physiological changes, because of edema of the airway, you'll have tough time intubating these patients. This is the normal anatomy of the airway. You can imagine this is the trachea, this is the oropharynx, tongue, and all that. Any pathology, either acquired or congenital, will lead to a problem in terms of either oxygenating the patient or intubating these patients. So there are a lot of mnemonics in airway management for us to easy to remember. The predictors of difficult bag mask ventilation, the mnemonic here is MOANS. The M stands for if there is any difficulty to have a seal, a good seal of the mask, and obviously it's very difficult to ventilate this patient. I'll come with the Malampati grade. If you cannot move the jaw forward and you cannot get a significant seal, there's going to be a problem. And usually male and older people or people with have beards, they have an issue with mask fit. And any disruption of the facial anatomy because of whatever reasons, and that will cause a problem in planning a good seal and bagging these patients. Obese patients, for the reasons I mentioned before, they have difficult, in ventilating these patients with the bag and mask. And because of loss of muscle tone in older patients, because of the soft tissue collapse, there will be obstruction to the bag mask ventilation, so you might not be able to do well. Patient is edentulous because of, again, it's very difficult to have a good mask seal. And the radiation is more important because of the changes in the tissue and rigidity of that. Tissue is very rigid and not pliable at all. And you will have very difficulty in intubating these patients or masking these patients. So you have to be careful. If anybody gives you a history of the neck radiation, they look normal, to look at. But I think you'll have really difficult time if you don't plan for it in terms of maintaining the oxygenation. Or if they have sleep apnea, or if the neck is stiff for whatever reasons, either surgery or asthma or pulmonary edema, because of the reasons you'll have difficulty in maintaining the airway there. There are different ways of predicting the difficult intubation. There are a lot of mnemonics here, lemon and all the other ones. I think the most common one, which is adapted by the Surgery Association of Trauma, is lemon method, which is popularized by Ron Waltz, who is an emergency physician there. The lemon L look externally, any abnormal face shape, dimension I mentioned before, like sunken teeth, no teeth, narrow mouth, obesity, and obvious any face or neck pathology, you'll have difficulty in intubating these patients. The second letter in the lemon mnemonic stands for evaluation. So what do you evaluate in terms of measurements? There are a lot of measurements in terms of less than 6 centimeters, less than 7.5, and it's very unlikely that anybody will have a tape ruler, with them. So the practical thing is, if the patient is awake enough, ask them to open their mouth, put their own 3 fingers in the mouth and between the teeth. If they can do that, most likely you have enough space to put the blade and intubate these patients. Or, for example, in the ED, if the patient comatose and if you can't do it, then passively you need to open their mouth and put your own fingers and approximate that. And the second measurement is the distance, the thyromental distance between the tip of the mandible and the thyroid cartilage. It should accommodate about 3 fingers. So what it does tell us is there is enough space when you are putting the blade in there. There is a space for the tongue to be displaced anteriorly. And we should be able to see the glottis very easily. Again, in the radiation patients, that might look normal, but when you try to intubate this patient, nothing moves because of the tissue changes. See, the measurements, this is 3-3-2 rule. The other one is the distance between the base of the neck and the thyroid cartilage. What it tells you is the relationship of larynx to the base of the tongue. If it is less than 2 fingers, that means it's too anterior. Even if you try to intubate, you might not, see it properly. The other thing, if it is longer than, more than 2 fingers breadth, that means it's too far below down. Even though if you have, the proper equipment, you might not reach it there. So these are the 3 measurements they recommend to evaluate. At present what we have is the Mellon-Party classification on the sedation assessment. This is what it assesses the size of the tongue in relation to the oral cavity, and because you are asking the patient to open their mouth to look into their mouth, that tells you how well the patient can open the mouth. And third is may indicate how well you can displace the tongue when you're trying to intubate these patients. And you're also asking the patient to extend the neck when you're doing this evaluation. So it evaluates the four things when you're looking for a Mellon-Party test. I mean, these are for, initially it's only 3 classifications. Later on it was modified by Samson and Young. They added one more classification to that. But that's not, important. Important thing is what you can see when they open the mouth. In the patient, you ask the patient to open the mouth. If you can see, there are 4 classes here. If you can see all the structures in the oropharynx in the back of your mouth, that is soft palate, tonsils, tonsil pillars, and uvula. If you visualize all these things, most likely it's very easy to intubate these patients. If you don't visualize anything, if you don't see the soft palate, all you see is the hard palate, then probably it's going to be very difficult for you to intubate that patient. And there are difficult variations in between. So the question is, how do you perform the test? There's a lot of variations in terms of who is performing this test, and where the patient, where the examiner is sitting in front of the patient, or we are standing when you are examining this patient. The recommendation is you should sit in front of the patient, ask the patient to open their mouth, extend their neck, and also the latest recommendation is to ask them to phonate, to say, say ahs, to see whether you can, see the structures or not. The disadvantage of this test is the sensitivity is around 60%. The specificity is very low. The predictive value is very low. It is very good in terms of extremes. If it is class 1, most likely the intubation should be okay. If it is class 4, most likely it's going to be difficult. But in between, there's a lot more variations in that. So if used alone, this test is not really a good test in terms of predicting the difficult airway. It has to be combined with some other measurements. The obstruction, the fourth letter in this is, if you have any obvious pathology like peritonsil abscess or retropharyngeal abscess, epiglottitis, any tumors or hematomas, it's going to be difficult to visualize even though the other anatomy is normal. This is neck mobility. If your patient cannot extend the neck at least 35 degrees, most likely it's going to be a problem to visualize the larynx, because you cannot extend the neck and you cannot place the blade properly and visualize this oropharynx. I mean, the common thing is, if your patient in an imaginary line between the teeth, if you ask the patient to extend the neck, the line should, touch the lower teeth. Okay, these are the assessment. I don't want to get into that. The other important test is mandibular protrusion. This is important because that tells you, when you are intubating the patient, if you can displace the mandible or not. The common test, they call it as upper lip bite test. That's what it tells you. If you ask the patient to bite their upper lip like this, that means they should be able to protrude the mandible and bite their lip. These are classifications. If you can do that, that's class 1. If the teeth come at the same level, it is class 2 or class B. Or if they cannot do anything at all, it's going to be class C. So that means if they cannot protrude the mandible, most probably it's going to be very difficult to do the intubation on these patients. This is the pictorial. So the recommendation is no single test is really good in terms of predicting the airway. You need to combine either Lemon method or combining the upper lip bite test with thyromental distance or Mallampati classification with any of these tests to predict if the otherwise normally looking patient is going to be difficult or not to intubate. What are the difficulties in terms of putting the extraglottic device? If you cannot open the mouth, obviously you cannot put any device in their mouth. So that's number one. The mnemonic here is rods. If there is an obvious obstruction, you cannot put any device in there. Or if there is an injury or disruption of the airway, for whatever reasons, you can't do that. And even if you can insert the device, if the patient has stiff lungs for whatever reasons, you cannot ventilate these patients. So what are the mnemonic here is short. The difficulty in doing the cricothyrotomy in patients in emergency surgical airways. If there is a disruption of the neck or any other structures, you can't do it. And hematomas, if the patient is very obese, you cannot find the landmarks properly, and you might not be able to get an access to the trachea. And for the reasons I mentioned before, because of the distortion of the soft tissue, with radiation you won't be able to do it. And if there is a tumor, you should not, you might not be able to do these things. So the important thing is, when do you know that patient is having a problem with breathing, and what are the signs of respiratory failure? I'm going from top, the initial early signs to the later signs here. You'll see the suprasternal or subcostal intercostal retractions. Usually it's very easy to see in the children in an age group which are in pediatric patients. You don't see that obvious in elder patients. And the abnormal posturing, because of the air hunger, patients try to sit up, try to breathe for whatever way they find a comfortable position to do that. And because of sympathetic stimulation, the patient is going to have tachycardia, hypertensive, the sweating, and then followed by low saturations, cyanosis because of low blood supply to the brain, confusion, restlessness, and finally bradycardia, hypotension, and coma. So it's important to recognize these things early on and try to intervene right away rather than waiting for the too late. Kevin is going to talk more about sleep apnea syndrome and morbid obesity. No matter how you look at it, it's a bad situation. You can't mask these patients. You cannot intubate these patients. They have other coexisting morbidity and mortality there. And the other important thing to notice is the marked decrease in tolerable apnea time. That means normal patients can tolerate the apnea for a longer period of time. The reason is the functional residual capacity is very low in these patients. The closing volume is high, and they don't have any reserves. So Kevin is going to touch upon pre-oxygenation, how we should prepare for this patient. Preparation planning is the key for all these patients rather than waiting for the last minute. And again, as I mentioned, important thing is incidence of difficult intubation in these patients is about anywhere from 13 to 20%. So again, the key is planning for these intubations, management of these airways beforehand rather than waiting for that, the last minute. And the positioning of the patient is very important. Simple changing the position will really markedly improve the situation or make it much more worse. This is morbidly obese patient. We didn't do anything, just put a little pillow under the head. The angle of airway, he's going to mention about that. What it is even if you don't do anything, if they are already compromised, over a period of time, they'll have respiratory problems. They'll obstruct. They'll have issues there. So if you take time, position this patient properly, I think you'll have a better chance of having a successful airway in these patients. Instead of doing that, if you take time, put some pillows there and under the head and the shoulders and position it properly, the ventilation markedly improves even without. And in these patients, these are the patients, even if you give small doses of whatever agent you like to do, I mean, they have problems in terms of airway obstruction. So, I mean, these things you need to be. The conclusion is there's no single test available to predict a difficult airway, either difficult mask ventilation. So you need to combine all the existing evidence out there, history, physical examination, to come up with and predict and plan for these airways. And as I was mentioning before, the early recognition of the respiratory failure is the key, and planning is the key to prevent these problems. And the last one is continuation of failed attempts. If you cannot intubate or if you cannot bag this patient, don't try to keep on doing the same thing, because it's not going to work. Either you need to call somebody who has better, skill sets than you, or do some other ways, plan B, which might work in these patients. You cannot continue doing the intubations, trying to intubate, then you cause more trauma and more problems. Well, this is the presentation. This is a similar, same case. The patient comes in with chest pain, air hunger, extreme weakness, a history of hypertension, had an MI 2 years ago, low ejection fraction, EKG shows acute MI. This is the respiratory rate is 40, heart rate is 100, pressure is very low, and saturations are in low 80s, and he's sweating, he barely can speak, and he has a full beard. So he comes to the ED, for you to help him out in terms of, cardiac intervention, whatever intervention he needs. So how do you manage this airway? And I will give it to Dr. Stater. He'll take you through this airway management here. All right.
So Satyam did a very nice job of just kind of going over airway evaluations. I want to focus a little bit more just to update it, what's going on with conscious sedation, what really conscious sedation means. Really more importantly, patient selection and kind of the way an anesthesiologist kind of algorithmically will approach an airway, which is a little bit different than most other providers just because it's the way we're trained. So the last case that Dr. Satyam, Dr. Charya was talking about, this is a patient that presented to me about 1.5 years ago for urgent bypass surgery. And he's pretty much got it all from based on the conversations that we had. And this is somebody who gets your attention, full beard, neck's greater than 20 inches. I can tell you he does not open his mouth well. When he opens his mouth, what you will see is tongue and nothing else. He's pretty sick, so this guy scares us, right? He certainly scared me. How about this guy? And how about this guy? Everybody's shaking in their boots. I can see you're all very nervous about anesthetizing these people. How about this man? All right, every single one of those people had a severe obstructive sleep apnea based on polysomnograms. Okay? I know Gail participated, I participated. John, I think you participated. This came out of a group at Hopkins where they took 56 patients. They have a large data set in sleep medicine there where they're taking frontal and lateral photographs of folks, pre-study and post-study. And so that we presented these to folks here. It took 20 anesthesiologists, 10 ENTs, and 11 internists. And we looked for folks, like stuck Dr. Cunningham in the internist category. We're looking for people that had the ability to do conscious sedation on people. And do you think that these people had OSA or didn't have OSA? And what we found, and then you looked once just with pictures. The second time, you got a little bit of history. They're hypertensive, whether they had coronary disease, whatever. Bottom line is, at best, we're about 60% accurate in predicting these people. So no better than the coin in your pocket when you're flipping it, pretty much. And this kind of goes to, there's a lot of stuff going on now. You'll see some things coming out of here. There's actually a multidisciplinary group now that's working at Hopkins, at University of Maryland, and they're looking at community-affiliated Hopkins hospitals, so Howard County for Hopkins and St. Joe's for University of Maryland, looking for some algorithmic approaches that we're going to be looking for these folks with OSA. Hopefully you'll see that within the next few months. Bottom line is, and I apologize, my daughter's special effects didn't transfer to these presentations, but when you have somebody presenting with OSA, the easy part is when they're diagnosed. So the mild diagnosed folks that don't need CPAP, you have the folks that are documented who are using CPAP and splinting devices, which it's getting better, but as I'm sure John will tell you, not everybody likes CPAP and frequently are very non-compliant. Suspected OSA, which is that first guy, we know he's got it. So I'm okay with that. The one that's frightening, obviously, though, is that 80 to 90% of these folks come to us undiagnosed. And so it's really been an educational fact for us, even, especially as anesthesiologists and with our surgeons, to say, listen, we need to start asking questions about these people. Because there really is a paucity of data of where you put these people, especially when you operate on them or when you sedate them. People that get narcotics, people that have abdominal incisions that affect the hemidiaphragm, lots of things going on right now. So this is really, if I could describe it now in our society, it's similar to when the ACC 15 years ago, where everybody needed a calf. And now everyone's getting beta blockers. So it's really in that kind of nascent, we're trying to figure out who's sick, and right now we're being very conservative. If you come in with a diagnosis of OSA at Hopkins and you're having surgery, you either need to be out of the operating room by noon or you're going to an intensive care unit bed. And that's just the way it is right now. So there's a lot of stuff going on, so you'll see this in a lot of different places. So in terms for today for objectives, I wanted to go over just the conscious sedation guidelines, talk a little bit about patient selection in patients that you're going to be sedating, and then talk a little bit about how an anesthesiologist would go after an airway that we get in trouble with. These are going to be responded minimal, moderate, deep, and general anesthesia. We look at responsiveness, so when you're in our lab or if you're providing anesthesia in the operating room, somebody is marking the responsiveness. If it's not an anesthesiologist or nurse anesthetist, someone is asking them questions, verbal stimulation, purposeful response is still moderate. Deep sedation, you may or may not be purposeful. You may need, glabellar tap, you may be smacked around a little bit for somebody to respond to you. And the airway tends to parallel that. So essentially, until you get into that, and I really want to kind of put your attention to moderate to deep sedation. Whether you need intervention with the airway, do you need to do a jaw lift? You may need an oral airway, a nasal airway. So that's kind of that divide. That's a gray area. Spontaneous ventilation, cardiovascular, again, once you get into moderate to deep sedation, you may start to see some compromise at that level. So these are CMS recommendations for monitoring. Interestingly, obviously blood pressure. EKG really isn't necessary, believe it or not, unless you have, at least their concerns, unless you're planning on moderate sedation. We'll talk a little bit about what planning means, or whether you think you have cardiovascular disease or dysrhythmia. So eventually, everyone in the cath lab is going to get an EKG, obviously. Everyone's having bronchoscopy or cardioversion is going to get an EKG. Other monitoring levels, level of consciousness, we talked about. These are the sedation scores that the nurses are usually providing, and they're marking these down for you. Pulmonary ventilation, observed auscultation versus capnometry. We'll talk about capnometry in a second. And then oxygenation and pulse oximetry. Pretty much everybody gets oxygenation. Observation or auscultation. How many people in here, when you're doing conscious sedation, you think anybody's counting the respiratory rate of your patient? Dead silence, right? Okay. Closed claim just happened at a dental operatory in Howard County, where it was a MAC case, which is what anesthesiologists will call a sedation case. Clearly, the patient, no evidence for 45 minutes of any respiratory effort. 18-year-old child, dead. So capnometry is the buzzword now coming up for deep sedation. And this is what the question is, and the reason I bring this up, so we're talking about level of consciousness. Let's go through one more, I think the next slide. This is the current standard from CMS. Came out about a year, I believe, year and a half ago. And where it says, presence of exhaled CO2. This is capnometry, unless precluded or invalidated by the nature of the patient, the procedure, or equipment. So joint is actually going through, I've talked to some folks that have had joint surveys thus far. The way they're getting around it right now is that they're saying that the facility just doesn't have the ability to do CO2 monitoring, meaning they don't have the money, they don't have the resources. We are in the process of preparing for a CMS survey here, which is not a survey, it's an inspection, followed by probably a joint survey after that. I do not know that we're going to be able to answer that question by saying, you know what, we just don't have the ability in the cath lab to do this. We don't have the ability in the PACU to do this. So you're going to see this coming to a neighborhood near you, hopefully within the next 6 to 9 months, I would think. And it's the right thing. And the reasons why. Hypoxia, as Dr. Chari said, follows hypoventilation. Okay, it's like the classic anesthesia board question, patient's bradycardic. What do? You give atropine, you failed your boards. Patient's bradycardic because they're becoming hypoxic and hypercapnic. So if I took a healthy Dr. Pruitt and gave him 5 minutes of oxygen at 10 liters a minute, how long would it take for him to desaturate if he just stopped breathing? 8 minutes. It's a long time. And usually when you hit that part of the oxygen saturation curve, you're probably going to be in trouble, especially in your patients. These are patients that have coronary disease, they have pulmonary disease, they have a lot of other issues. So administration of oxygen, as we said, that will give you a longer interval for apnea. Non-anesthesia providers, again, it's not a knock on anybody, but it's like, I don't do anything else. You guys are actually doing important medicine stuff. I'm just taking care of their airway and making sure they breathe. Sedation being performed in remote areas. Everyone in this room, who has privileges here to do conscious sedation? Okay? No one's in an operating room for the most part, right? You're pretty lonely where you are, especially at 2 o'clock in the morning. Okay. So this is, again, MAC is called monitored anesthetic care. It's what anesthesia providers call conscious sedation. This is, if you're looking at, these are our closed claim studies. As I said before, it's like the 3rd or 4th time we've given this talk. Anesthesiologists have been killing people regularly since the early 50s, so we've got a lot of data to back on, and we're actually very good at reporting our data in terms of outcome. What's interesting about this take-home is after about 2,000 cases, the severity of injury for monitored anesthetic care versus general anesthesia is essentially the same. So for the cardiologist in the room, none of you guys would do this to me anymore, but do not medically clear a patient for surgery for sedation, but not general anesthesia. They're either ready to come to surgery or they're not. Because number one, we never know if we're going to have to, quote, we call it upgrading from a sedation case of general anesthetic. And quite frankly, the indication doesn't really make sense. The only death in over 10 years at the outpatient center at Hopkins was a case done under straight local anesthesia. It was a digit amputation on a patient, had severe coronary disease, got tachycardic, had an MI, and died. So it's frequently not the anesthetic or the airway management that causes the death. It's usually the patient's comorbidities, which I think we all tend to know that. We tend to sometimes not think about it. At the bottom, though, 40% of these occurrences resulted in death and brain damage, and they were thought to be preventable, which is why that's why pulse oximetry and now capnometry is going to be coming around in terms of what should be offered in terms of the way we sedate our patients. Rescue. Again, this is a statement from actually practice guidelines. Accordingly, practitioners administering these drugs should be qualified to rescue patients from any level of sedation, including general anesthesia. The majority of us, it's certainly in the cath lab, are looking for mild to moderate sedation at most. Okay? ER physicians, if you're going to like set a joint, you're looking for at least deep sedation, most likely, I would think. That being said, if you're looking for moderate, you need to be able to rescue deep. That is the expectation. So you need to be comfortable. If you're planning on giving deep sedation, the guidelines say that you should be able to rescue that patient from a general anesthetic. It gets a little bit scary when you're by yourself. So airway emergencies are like codes. Worst case scenarios are low frequency events or things that we should be preparing for with practice and simulation. Do we do that? Nah. Okay, we're going to start, but we never do that. Okay. So if an anesthesiologist comes in, my exam stops right about here. So it's an airway evaluation. It's a heart-lung evaluation. And I'm not going to go with the airway. Dr. Chari covered that in depth. Just basic things, drug allergies. It's interesting. We always ask about anesthetics if they've had problems before. Tobacco, alcohol, substance abuse issues. Again, focused physical exam. Labs aren't really the focus of this talk. But this is basically, if we show up to help, this is what we're going to be asking. ASA physical status, I put this up there just for familiarity. This was never meant to be a predictive. This has been modified a little bit. It's been around since the 50s. But basically, for our purposes, if you have stable coronary disease, you're in ASA 3. If you have unstable coronary syndrome, you're in ASA 4. It has been looked at in terms of litigation. If somebody is coming as a salvage procedure, emergent aortic dissection, come to the operating room, it is helpful to call that person what they really are, which is a 5E. Like, meaning they're not going to survive whether you do this or, if they don't do this, they're not going to survive most likely. Again, risk factors. This comes from a study I'll talk about a little bit later in the slides. But basically, obviously the things that Dr. Chari talked about, but these are significant risk factors. So think of your patient population. Me, a man over 50, not so much obesity, but sleep diet, OSA. Those are three huge things. And there's the propensity score now we're doing for sleep apnea, especially in the United States, is really high. So that's a lot of your patient population right now is considered at risk for a difficult airway. And that's without doing any of the measurements that Dr. Chari was talking about. So the ASA difficult algorithm, it talks about difficult ventilation, difficult intubation, difficulty with cooperation or consent, and difficult tracheostomy or surgical assessment or surgical securing of the airway. The two take-homes for this, if you call me to help you, my question is, can I mask them? Not so much can I intubate them, can I mask them? And really, if I can't mask them, can this patient lie flat? Because pretty much everybody in this room, unless you're doing bronchoscopy, the patient's going to be lying flat. And that's difficulty with cooperation or consent. And that's also something I really want people to think forward about. If you've got that first patient who's kind of in extremis and he's in the ED and he's having a non-STEMI, you think he might get better or he might not, and do you want him doing this on his back while you're trying to do what you need to do? So that's just something to think about, but it's the first thing that I think about. It's like, oh man, and that's when I start thinking, which direction am I going to go with this particular patient? Actively pursue opportunities to deliver supplemental oxygen. Again, this goes back to my Air Force days. I never wanted to jump out of an airplane, but if I did, it's at least at 5,000 feet. So the more time that you have to think, what you'll see when Dr. Chari or one of my other colleagues show up is we tend to slow stuff down. We just want to slow stuff down. And having the patient saturated, the name of the game here is hypoxic brain damage. If you can get by, they can have an MI, they can have renal failure, they can have all kinds of stuff. But if you don't make them brain injured based on their airway and our lack of approaching it appropriately, it's going to be a better outcome for everybody involved, obviously including the patient. So supplemental oxygen as much as you can give it. Management choices, we're not really going to talk much about B, non-invasive versus invasive approaches. And awake versus intubation attempts after GA. Pretty much everybody here, in the ED, it's like someone's in extremis. You're going to most likely put them to sleep and try to intubate them. That's the way most emergency physician protocols are made. Preservation versus ablation and spontaneous ventilation. Do you give them muscle relaxant or not? I talked to a majority of my ER colleagues, and they're like, that's algorithmically the way they're trained. Whereas an anesthesiologist, we're algorithmically trained to not do that. It's like we don't want to burn, we consider that burning a bridge. If the patient's like breathing and oxygenated, we kind of like that. We like to leave that alone unless they can't lie flat or unless their other comorbidities are going to cause a problem down the road. You can stop me at any time now. I feel like I'm kind of going fast, but try to save time for questions. This is in your packet. It's a busy slide, but this is the ASA difficult airway algorithm. And where the red circles should be flying out onto the screen. We're working on the right side here, And really what we're talking about is intubation attempts after induction of general anesthesia. This is somebody that you thought you could intubate and you couldn't. And then the next question is, the splitting here is face mask. Can I mask the patient adequately, or can I not? And if I can't, that puts me on the right side of the algorithm. So face mask ventilation is not adequate. Consider or attempt an LMA. How many people in here know what an LMA is? Excellent. How many people here have put an LMA in? Even better. Okay, not very many hands, all right?
I was wondering who Allie Mae was.
Allie Mae, exactly. She was one of the Clampetts. LMA is a laryngeal mask airway. And this was brought initially, used almost ubiquitously about 10 to 15 years ago in the UK. This is used frequently now as a, I don't use it much in cardiac, but as a primary anesthetic. The idea being, this is a blind technique. This is something that you learn how to put in blindly. You can see that it actually, it tends to hold anywhere between 20 to 30 cc's of air in that cuff. Basically goes down around the area of arytenoids, allows you to bag the patient. It takes away the upper airway. So if you can't get a good mask seal on a patient, this is the thing that you can plop in. We use it in this country now, obviously for a lot of these anesthetics. They go down all the way to infant sizes now, up to large adults. But it's also what we call in that airway algorithm a bridging device. Okay, this is something that will bridge us. If I've got somebody I put to sleep, I can't mask them, I'm trying to get more time, I'm trying to think about, I'm waiting for my surgical colleague to come and help me, this will buy you some time. So one of the things that we'll talk about at some point is we're going to try to make as many opportunities available to you guys if you would like to come into the operating room, just to throw 2 or 3 of these in under like perfect ideal conditions in the operating room. We can play around a little bit just to get a feel for it. But it's something that has saved me on many occasions. This is just something that anesthesiologists tend to tinker because we're bored. We watch surgery for a lot of time. There's not a whole lot else to do. This is, this is something that I played around with, but what this is, a fiber optic scope is the black tip you see coming through there, and that's going through a laryngeal mask airway. This is a patient that I couldn't intubate, that I burned a bridge, and I probably gave muscle relaxant so the patient's not breathing spontaneously. Put an LMA in. Okay, well, I'm bridging, so I can mask the patient with the LMA. I've put a fiber optic through something called a DIDO, which is kind of like it's just basically a catheter, because the fiber optic scope has an optical device that you can't slide an endotracheal tube on. But the more important piece is, if you look at that side piece off the top, that's going to my ambu bag or my anesthesia circuit. So I can, and I have done this for half hour, 45 minutes, while I'm trying to figure out what I'm going to do. So the patient's still oxygenating, hopefully. I may be inflating the stomach a little bit. It's not perfect, but again, patient's not hypoxic, and that's really the name of the game that we're trying to achieve. This is called a bougie, or we call it a poor man's fiber optic scope. The one to the left is the original one. That requires to be sterilized. We have these available, and again, everything that we've talked about, we've kind of gone through the difficult airway cart based on the root cause analysis to make sure that when somebody shows up to help you, these devices are available to either yourself or the anesthesiologist. It's rigid. You can see the one on the left is a little bit bent. I first saw this, a nurse anesthetist, when I was in the military. We were struggling in the emergency room, and he had a little bag, and he pulled this thing out, and it was like, wow. But you can actually, if you do these enough, I will tell you that you can actually tell the difference when you're popping down the cartilage of the trachea versus actually the esophagus. So it's a very helpful thing. What frequently happens for those of us who try to intubate is, when Dr. Chara was talking about now the airway, there are 3 axes that you're trying under direct laryngoscopy to line up. And frequently you'll get within about 2 to 3 millimeters of seeing the vocal cords. You just can't see up high enough. It's 2 to 3 millimeters. This is something that, quote, is blind, but it gives the ability that you know that you're passing something in the right direction. And frequently, if somebody's holding cricoid, they can feel it popping as you're popping it down. Again, blind technique, but it's pretty quick, down and dirty. Next approaches, which really kind of have revolutionized what we do. These are Video laryngoscopes or glide scope is what we have in this available in our facility. It is a little bit challenging to play with, but what happens is that extra 2 to 3 millimeters of anterior visualization that you can't get this way by lifting the patient's head, it actually provides for you with a fiber optic scope. The challenge with this, it's a little tricky. It can be very frustrating because you can see the vocal cords very nicely on the screen, but you're working at a little bit of a deficit. It's like kind of, like I would imagine doing laparoscopic surgery for the first time. You can't really, you're past pointing, you can't quite see where it's going because your eyes aren't matching it exactly. Usually requires a stylet, but again, very helpful. This is an air track. We'll talk about basically the same thing. These are disposable. They run 70 to 80 bucks. We're starting to provide these for our difficult airway carts. So basically it's a video laryngoscope. It's a peel pack. They come in colors based on the size, like small, medium, large, the airway, the size of the patient you're using. These are something also that we felt would be necessary to be available. Okay, so we've done what we can do. We've done the LMA, we've done the air track. We still can't intubate the patient, so we're still kind of working. We're trying to stay away from that very bottom corner, which is an emergency invasive airway. But it's on there for a reason, so we'll get there when we get there. This is called an LMA track. This is, again, something a little bit different. We have these. I put it up. I don't really like this too much. I've had it for a while, and I really don't see a whole lot of utility with it. You can see that it's rigid. It allows you to put a little bit larger endotracheal tube through that, up to like a 7.5, which is not huge, but it's bigger than a big man. So basically, it's an LMA that visualizes the vocal cords. I've been successful with this with a fiber optic scope, helping put a fiber optic scope and then loading it through. But again, just something, it's in a study that we're going to talk about. So these are, these are just familiarity things. Combi tubes, these are non-invasive. These are on there and they should be on our carts. These are blind techniques. Again, you're not putting an LMA in. These are something that anybody, EMTs are trained to put these in the field. When I was a resident fellow, half of the city in Baltimore, if you were on the east side, Hopkins trained the EMTs to intubate. Maryland put in non-invasive devices. So this is a combi tube. Has 2 cuffs, one ideally for the trachea, one for the upper airway. This is a King airway, since similar. This is a blind tube at the bottom. The other one had a ventilation port on it. This is meant to go blindly into the esophagus with an aperture and a cuff, kind of like an LMA, to hopefully ideally get that through. This is what was routinely put in. Actually, interestingly, there is a closed claim that came out of DC where an EMT successfully placed that into the patient's trachea in the field and killed a patient that way because it's a blind pouch. So again, these aren't ideal. We're kind of getting down to the desperation. We're trying to buy time. So which is where we are here. Can't intubate, can't ventilate. LMA didn't help us. Emergency non-invasive airways failed, okay? And that's where we're getting into needle cricothyroidotomies. This again is something that I assure you, you could do if you were trained to do it. This is not trying to do a tracheostomy or percutaneous. This is a 14-gauge angiocatheter. Everybody can find a cricothyroid membrane, put a 5cc syringe on it. When you're an extremis, I put it with half saline in, hit the airway, aspirate but air bubbles out, and advance it just like you're starting an IV. Okay, the problem is, we have in some of the operating rooms, you did not have this on your airway. You did not have what's called a jet ventilator. Again, inexpensive, about $300–400 to buy. Basically what this will do is that, I'll show you another picture in a second, but basically you connect this 14-gauge angiocatheter to a jet ventilator. It runs off to 50 psi off the wall, or you can regulate it off an air tank. And again, these will be modified on the difficult airway carts. But again, the idea is you can't really ventilate somebody through this because it's passive ventilation. So someone who's got bad lung disease, I actually killed a patient with a pneumomediastinum in the ICU with one of these about 15 years ago in an extremis situation. So it's a fairly high rate of flow, but again, we're still trying to oxygenate this patient. And this is what it looks like in real. So that's the orange is a 14-gauge angiocatheter. It's just a little ball snap valve. You can see there's a regulator on it, sets it to 50 psi. But you can oxygenate somebody through this for 5, 10, 15 minutes while you're, again, trying to get somebody who knows how to use a knife to come help you at this point. And then we're down to the surgical airway. And it's on the algorithm for a reason, and that is an issue. Hopkins has an ear, nose, and throat. They have chief residents, but they have one based on an RCA they had about 5 or 6 years ago. They have an ENT that is in-house 24/7. The reason is they had a pediatric, I want to say the child was 8 or 9 years old, lost the airway. The provider happened to be an anesthesiologist, did a slash trach on the patient, cut both carotids. So they felt that as part of their RCA, it would be more important to have an ENT in-house. So there's lots of ways to get to where we're going. Obviously, in a small community hospital, we're not going to have an ENT here 24/7. But the thought process that we're going through really is what we're trying to talk about. So, and again, there's just quick pictures. I'm not going to spend a lot of time with this. This is kind of a busy slide, but this is what's going on now, that airway algorithm we talked about. This is a study that came out about a year or two ago from a large, basically our hospital, but in France, 300 plus bed tertiary care type hospital, where they looked at grading folks and they tried to modify the airway algorithm, putting folks to sleep and using a couple of devices. And they graded mass ventilation. So the bottom line is that if you were grade 3, you don't see that much here in the operating room. You might see it. We put somebody to sleep and we screwed up. So you might see Dr. Char and myself with 4 sets of hands or 3 sets of hands trying to mask the patient while bagging the patient. Grade 4 is that you just can't mask them. 1 and 2 is obviously less than that. So they graded these folks. They basically put everybody to sleep, except for folks that they knew previously had difficult airways that had to be secured in what we call an awake fashion, so an awake fiber optic. And a lot of patients, so over 12,000 patients. And the bottom line is they were very successful. What they did is the majority, if you look down the left side, the majority of the folks were intubated with a curved blade, a Macintosh. The folks that they couldn't intubate of that group, another 200 were able to be intubated with that bougie I talked about, that gum elastic bougie. The group that was left was like 30. Those folks, they were successfully intubated with an air track, and that was that kind of fiber optic video laryngoscope we talked about. The ones that they couldn't intubate with that, there were 4 left. They intubated with that air track with a bougie. So again, this is kind of one of the first, and there's a number of these studies that are starting to come out in our literature now where people are starting to take these like bridging devices and they're trying to pick and choose off the menu that airway algorithm and try to approach people as they come down the airway. Oh, and the grade 4 folks, they use the C-track, that LMA piece that I showed you with the video piece. That was the reason I left that up there. So in summary, conscious sedation, pre-procedure assessment, appropriate monitoring, and again, the question that's going to be is where capnography or CO2 monitoring comes in this hospital. You know, Gail has been very actively pursuing it. Jason Marks is actively pursuing it. We'll probably have something available. And the key to that is not just having CO2 monitoring, but we're talking about CO2 monitoring for your patients up on the floor as well. So it's like a central type monitoring. So we're looking at bundling that for the whole hospital. Again, anticipate the need for rescue. It's something that we just don't think it's going to be a problem, but you could have a lot of folks with, and you do, I tell you right now, you have a lot of people with obstructive sleep apnea that aren't diagnosed that are presenting to you for procedures. What is becoming more and more apparent to folks in the sleep medicine literature is that it's the overlap syndromes are the people that are most at risk to have problems. So they are your patients. They're patients that are hypertensive, patients with coronary disease, patients with asthma, patients with COPD. Those are the patients that do the worst with obstructive sleep apnea. People like myself who just have OSA who are relatively healthy really don't have much problems when you sedate us. Patient selection. Do I need help maintaining securing the airway? And that is really the take home for this message. And it's taken from the emergency room, it's from the front door of the hospital to the cath lab. If you guys feel that you have a concern that you may need some help with, call. And it's our responsibility to help you 24/7. And that's what we're trying to do at this point. And there are mechanisms in place that are being developed as part of this, but the idea is that, you know, there's somebody available to you. The worst scenario is in the middle of the night, if one of the anesthesiologists is tied up doing a procedure, we have ACOG rules just like you do. We're 30 minutes away. So if you think you need help, we would like that 30-minute call when they're calling the cath lab in. So if you've got patient 1 and you're coming in, have them call us, and we'll come in with you. 'Cause that's our job, and we need to start doing it more. So airway algorithm assessment, again, keep oxygen on your patient as much as you can. Call for help. That was actually, if you looked at that, I think you have it in your pack. But the first thing you do, if you can't intubate, if you can do something, call for help. It's always having infrared. Bridging devices we talked about, non-airway, non-invasive airways, and then emergency invasive airways. That's it. Any questions?
Patient selection in that, the usual scenarios, we see someone in craft, you can kind of identify through the various mechanisms we talked about a little bit who's at high risk.
Right.
Now, the majority of those people don't have any problems at all.
Right.
They don't necessarily need to call anybody.
Right.
But what are the things that we can do to change our approach or to minimize the risk or to avoid having to call you, for every patient, which would be like 20 or 30% of our patients?
Right. I mean, one of the things that I would, first of all, really good, which is one piece. If you, and you know, it's like evaluating any of the literature. A lot of this literature is going to come from academic institutions. So you're not going to have the same finesse in terms of the way you manage the patients, the way you sedate your patients, things like that. That closed claim study slide, one of the things they came up with, I mean, how many people here, when you do your conscious sedation, use more than one drug? Probably everybody, right? Everybody uses midazolam and fentanyl because you guys can't use propofol. That's one of the things that came out of that, is that those are patients that if you use more than one drug, it's a synergy of the drug. It's narcotic, essentially, with the OSA patients that are a problem. Now, if you give them 25 or 50 mics of fentanyl with a low dose of midazolam, they're probably going to be fine. Usually when we get involved, and as we've had in the past, it's either the nature of the procedure, it's a AAA stent or something like that, or I saw somebody roll by me on Monday that I was amazed. It looked like the picture that Dr. Chari showed, but she was laying relatively flat. And that's kind of where I look at it is, if you have somebody that you think looks like that, because you know, well, you know, I won't go through respiratory mechanics, but you know what their closing capacity is, you know what their residual volumes are, you know that patient is living on the cliff. And if you have concerns with those folks, if they can lie flat going to you, they're probably going to be okay with a little sedation. But if you think it's going to be like a complex, long, multiple stents, things like that, and that looking at that patient, those would be somebody that I would consider. And it's not even, it's almost even like it would just be a heads up. We wouldn't have to be becoming involved in your patient. And that's kind of where I get involved. Where it usually goes badly is that when you do your normal sedation on a patient like that, and if they're not cooperative, they're having trouble lying flat, and they wind up getting more. And I will tell you that very rarely does that happen in this hospital, thank goodness, because of your experience. You just kind of fight it out. But that is where I would recommend somebody coming in and say, you know, if I come in and give that person 50 of propofol so you can complete your procedure and manage their airway for you, you're done. And that's where I've had problems.
The goal is to improve the awareness so that you know which patients are going to be different. As he was saying, you're all very good. The incidence of problems is extremely low here. But with this talk, with this awareness, what you have, if you do little things and plan ahead, I think we can even avoid what you have, these problems.
I think the next step, in 1 second, Matt, is that those are also patients that I think you're going to have a whole awareness for OSA, and I think those are actually patients that you should be monitoring capnometry on. And you will have that available to you in the lab. I think that will be very helpful to you. Because if you see people that are holding their breath and obstructing and things like that when you're getting started and you've only given your normal, I think that's going to be an awareness issue that comes up as well. Because we don't. I mean, I guarantee you, I can pull 50 reports and they're going to say adequate. They're not going to say, nobody counts patients' respirations. They just don't. But they will count CO2. They'll say positive or negative, and you'll be able to see it as you're operating, just like you're looking at, because I know we all kind of pay attention to the pulse oximeter, because you hear that too. Does that answer your question? It's kind of a long-winded answer.
I mean, I didn't know, patient goes from prep, you kind of think they're a little bit high risk, they go into the cath lab or procedure room. It sounds like, you know, obviously you can minimize your number of drugs, you minimize the doses, that helps a little bit.
Right.
Whether it's different drugs or different doses that you can use, or positioning. You had the one picture where the woman's kind of propped up a little bit. Does that help?
Well, that's for intubation. Those are to kind of line those things up. They don't really help in terms of getting you out of
your airway open.
Not really.
Except for morbid obese patients, positioning helps.
But that's what I'm trying to figure out. If we have probably 25 to 30% of our patients are obese.
Right.
Obese.
Right. We already know that. So you already know they're higher risk.
Mhm.
But what do you do about that? I mean, they can't call
The
you
best
to give you a heads
person
up
to
for everyone.
advise that is the patient themselves. If you ask them what is the best position, how do you sleep better? I mean, they tell you, I like my head up a little bit. I mean, if you listen to them, most helpful situation is that. And the other thing is the bridging devices you're talking about. If you can help all of you in terms of just doing LMA, I think that's a tremendous help in terms of maintaining the oxygenation for these patients. Instead of going through all of the intubation, we are there for that one. But if you know the simple, just LMA bridging device, back mass ventilation is
Just
going to
a
be
nasal
very
airway
difficult.
sometime will buy all that time.
Right?
A little nasal
Oh, yeah,
trumpet.
nasal
or something
trumpet.
like that, 'cause
Yeah.
the tongue is back.
I'm sorry.
There's, when we take our moderate sedation test every year, if you have someone who's a Malpai 4, you're supposed to get anesthesia kind of consulted on that, it seems like, when we take that. Now, I don't routinely call you guys and say, I got a 450-pounder here who I think is going to be tough. Do you want us to, it sounds like the next step, at least to kind of give the phone call and say,
there should
we're
be
doing this calf, looks like he's
yeah.
going to be okay, but just want to let you know he looks like he's a big
Yeah,
kid.
and to be honest with you, frequently, I had Kim Wolf. It happens, and you guys don't know it's happening. I mean,
Okay, yeah.
Kim will say,
So
you know
that-
what, we got this patient
QB's
coming for
coming.
a pacemaker and blah, 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 blah. Who's around? And that's what we want. That really is. I mean, and the thing is, especially if, in the witching hour that I get very nervous about here, and we kind of fight this battle back and forth, and this is something Dr. Charter and I have talked about, the general anesthesia group has somebody on a pager till 5:30 at night. And we're transitioning over the summer, but in cardiac, we're going to do the same thing. So we will guarantee that somebody's here. Because my concern is the worst scenario is like 4 o'clock, 4:30, when you guys are coming here from someplace else, and it's traffic. And somebody's, I live in Hunt Valley. And I'm being called while you're in there, while you're struggling. And that's
early
a real
intubation
problem.
too, I think, is key in some of these patients too. If they're,
Oh, yeah.
in decompensated heart failure, huffing away and having their infarct,
Absolutely.
Intubate them, take that time to get
Right.
their airway under control and get them under control.
Exactly right.
Particularly the patient who had RCA, I think that was my patient.
Right. Anything else?
Thanks
All right.
for-
Thanks for your time, guys. Appreciate it.